Okay, so I'm very disappointed. Came out here thinking I would go to watch the Nationals play. So they flew me in last night, missed that game. For reasons that are unclear to me, they play at 4 in the afternoon today. Don't understand that at all. Then they play at 1 tomorrow, so I don't get to see them at all. So what we're going to do at 3 o'clock, the bus is coming. We're all going to the baseball game. We'll talk about endocrinology periodically. What's that? You want to go? I'm serious. We'll just go. The bus is coming? Okay. All right, so what we're going to talk about this afternoon, the first 2 hours, we're going to talk about Cushing's. The third hour, we'll talk about Addison's. With respect to me, that's me. If you have any questions about anything after this is over with, feel free to email me, david.bruett@evilempire.com or vcahospitals.com, depending on your frame of mind. And then all of the slides that I'm going to show today and tomorrow are all on this website, veterinary-diagnostic-investigation.com. So if you want, they're all PDFs, so if you want any of the notes, you can download them there. You can also call me, but it's very difficult to get a hold of me on the phone, so just email me. We just moved our hospital, so we moved from a relatively small clinic. 2 months ago, we just moved into a 43,000 square foot hospital in Los Angeles. And so now we have 50 doctors, 200 and something employees, and 0 HR issues. It's just phenomenal. Everybody's a very happy camper. So if you want to come out and take a look at our hospital, if you're bored and don't have anything else to do in Los Angeles, let me know. So first of all, we'll just define some terms. Cushing's syndrome really refers to any cause of elevated cortisol. And so primarily what we deal with and what we deal with on the human side as well is pituitary-dependent hyperadrenocorticism. And PDH is basically Cushing's disease. That's the disease that Harvey Cushing first described in the early 1900s. Now, for those of you who are Harvey Cushing fanatics, how many people are Harvey Cushing fanatics like me? Really? Seriously? Okay, so here's the deal. If you go on eBay and you try and buy Harvey Cushing paraphernalia and you see that somebody with the screen name Adrenal is bidding on Harvey Cushing paraphernalia, you should just get the hell out of my way. Because I'm going to buy it. I'm going to beat you because we have all these little computer programs set in a place to out-trump you by a nickel if I have to. And if you get really bored and you come to LA, I have a movie of Harvey Cushing doing his 2000th brain tumor surgery. And it's quite spectacular because he was basically doing it in a room about the size of this room. And at the time he started doing neurosurgery was 1905. And in 1905, there's no CT, no MRI. Anesthetic agent of choice was one, and that was ether. No antibiotics. And so he would open up people's heads based on where he thought the lesion was on his neurologic exam. He would knock them out with ether, open up the skull to get to the part of the brain where he thought he wanted to go, and then wake them up because they didn't really know what else they were doing. So the brain doesn't really have pain fibers in it, so they were mucking around in there. They learned a lot about the brain, what not to touch. And when he discovered a group of people that had consistent clinical signs, they were pot-bellied, big buffalo fat pads on their back, abdominal bruising, glucose intolerance, some of them were diabetic. He discovered at necropsy that all these patients had pituitary tumors. And so he published a paper on basophilic adenoma of the pituitary body and their clinical manifestations. How many people have the first edition of that paper? Huh, I do. Yep. He never actually operated on a patient with Cushing's disease. He operated on a lot of other people with pituitary tumors for reasons that we'll talk about. But he was the first one to develop the surgical approach to getting to the pituitary, which we'll talk about later, which is the approach that we still use today. So for us in veterinary medicine, about 85% of what you see in practice and what we see in the lab is going to be the pituitary form. Adrenal-dependent hyperadrenocorticism is either a unilateral, rarely a bilateral secreting adrenal tumor that's producing cortisol. And recently it's been described in the literature, and we've seen 5 or 6 cases in the last few years of what's called meal-induced or food-induced Cushing's disease. And this is a very uncommon disorder in people, now described in the dog. And basically what it is, and we'll talk more tomorrow if you're here about diabetes, but basically this is a disorder where you're born with aberrant expression of receptors called the GLP-1 receptor. And the GLP-1 receptor normally lives in your pancreas. And whenever you eat a meal, GLP-1 is secreted from your intestine, goes to your pancreas, tells your pancreas to produce insulin. What happens in these dogs, though, and what happens in some humans, is that they're born with these GLP-1 receptors in their adrenal cortex. So every time they eat a meal, they secrete cortisol. And in dogs, what we see is that these are dogs who present into your clinic with classic clinical signs of Cushing's, except they're really young. They're 4 or 5 years of age. They're PUPD, pot-bellied, losing their hair, high alk phos, thin skin, whole 9 yards. You run an ACTH stim test on them, and it's normal. You do a low-dose dex, and it's normal. You do a fasting urine cortisol to creatinine ratio, and it's normal. And now you have a really agitated owner because you spent a whole bunch of money. And what these dogs, the way that if you have a dog like that, a young dog with classic signs with normal endocrine tests, email me. We'll send you the protocol for diagnosing meal-induced Cushing's, which is basically a pre- and a postprandial UCCR that the owners do at home. And the nice thing is that these dogs will have a marked rise in urinary cortisol after a meal, and they respond really well to trilostane. They just have to take it twice a day. Every time they eat a meal, they'll take a low dose of trilostane. So again, and we'll talk more about atypical hyperadrenocorticism as well, but that disease tends to occur in older dogs, just like classic Cushing's. And then the last form of Cushing syndrome, which occurs mainly in humans, it's been sporadically sort of pseudo-reported in dogs, is where you have a patient who has a tumor outside of the pituitary that's secreting ACTH. And so in people, this is most commonly a lung tumor. The lung tumor produces ACTH, stimulates adrenal release of cortisol, all the classic clinical signs of Cushing's, but it's really hard to diagnose because their ACTH levels indicate pituitary. They scan their pituitaries and they're normal. Then they have to go on a hunt and find the tumor. Fortunately for us, this is pretty rare because these tumors in people tend to be really bad. They tend to be very aggressive malignant tumors. And they usually don't die from Cushing's, but they die as a result of their primary tumor. If we look at the underlying pathogenesis, how do they get the disease and what is the hallmark of the disease? In us, in humans, we're diurnal secretors of cortisol. So your cortisol was the highest it was going to be at 8 o'clock this morning or whatever time you rolled out of bed. It's going to be the lowest at midnight. And that's why all adrenal function tests on humans that are assessing their pituitary adrenal axis usually involve some type of midnight test, whether it's midnight urine or midnight salivary cortisol, but you'll get screened at midnight. Dogs and cats are not diurnal secretors. They don't have diurnal variation in their pituitary adrenal axis. They're episodic secretors. So every 20 minutes, they secrete ACTH, followed by a rise in plasma cortisol, no difference morning or evening. We know from studies, we work with the people at UCLA and Cedars-Sinai in Los Angeles, and they probably see about 1,000 pituitary tumor cases a year. Of those 1,000 patients, maybe 10 of them have Cushing's. The rest of them have prolactin-secreting tumors, growth hormone-secreting tumors, tumors that secrete various fragments of anterior pituitary hormones. But Cushing's disease is very uncommon. So it's estimated maybe 1 in 1.5 million people get diagnosed with Cushing's. Conversely, in dogs, it's about 1 in every 1,200 older dogs gets diagnosed with Cushing's. So we see about 90 to 100,000 new cases of canine Cushing's every year in the U.S. And one of the things that we're interested in is trying to figure out why. Why is it so common in dogs? Is the dog a good model to look at for treatment options in people? And really, what is the best way to treat it? And we'll talk more in the second hour about treatment. We do know that the main problem with Cushing's is too much cortisol because we can reproduce the disease in dogs with exogenous steroids. So you've all seen dogs treated by other veterinarians with high doses of steroids that come in with all the classic signs of iatrogenically induced Cushing's. And when you stop the medication, symptoms go away. And when you treat dogs with hyperadrenocorticism with surgery, adrenalytics, adrenal enzyme blockers, the clinical signs go away. So the vast majority of the symptoms are all mediated by cortisol, with the exception of the presence of a mass. So in some dogs, the adrenal mass can be the primary presenting complaint. In some dogs, the pituitary mass can be the primary presenting complaint. This is Harvey sitting at his desk. He did what all people of his era did, and he smoked. This is what killed him. He died of emphysema. And when he was close to retirement and close to dying, he told one of his surgery residents, he goes, look, when I die, and you do my autopsy, you're going to find I have a tumor in my left parietal lobe. And they said, well, what the heck? If you think you have a brain tumor, you're sitting at that point, he was at Yale. They go, no, this is the world's leading center for brain surgery. Why don't we take it out? And he looked at the resident and said, there's only one surgeon in the world good enough to do this surgery. He goes, and that's me. So when he died of emphysema and they did his autopsy, he had a tumor in his left parietal lobe. The guy was spooky, really spooky guy. He also married well, which is a key thing. Marry rich. Yeah, so I did not accomplish that. He did. So he had a nice life going for himself there. Now, if we look at the pituitary form of the disease and we look at tissue that we take out of dogs with pituitary-dependent Cushing's, what we find is lots of different pathology. Rarely do we find carcinoma, which is good, because pituitary carcinomas are bad because they're highly invasive, they invade into the brain, and they also have the potential to metastasize within the brain. They don't leave the CNS, but they can spread within the brain itself. Sometimes what we'll see in dogs, and this is maybe 30% of the time, is like if we looked at histopathology of a hyperthyroid cat, you see areas of hyperplastic tissue. Well, sometimes we'll see that in dogs with Cushing's, and we think that's at the beginning of the disease, where these areas of hyperplasia precede the development of an obvious adenoma or a tumor of the pars intermedia or pars distalis. The classic disease is a tumor of the anterior pituitary, also known as the pars distalis. Maybe 70% of the cases arise from that part of the pituitary. And about 30% arise from an area in the pituitary called the pars intermedia. Now, people, we don't have one. We don't have a pars intermedia. How many people practice equine medicine? Oh, excellent. Oh, there's one. Oh, well, there go all the horse jokes. We won't tell any horse jokes. All equine hyperadrenocorticism is a pars intermedia mediated disease. And we treat horses with dopaminergic drugs because that's what regulates the pars intermedia. So about 20 to 30% of dogs have PI tumors. You guys see these clinically, even though you don't know that, because these are dogs, classic clinical signs of Cushing's, don't suppress on the low dose, don't suppress on the high dose. And that's because the pars intermedia does not have a blood supply connecting it to the peripheral blood. The pars intermedia secretes ACTH only when there's a loss of dopamine. So dopamine tonically inhibits the release of ACTH from the pars intermedia. In the horse and in 25 to 30% of dogs, loss of dopaminergic neurons results in ACTH overproduction and all the classic signs of Cushing's. And again, later on in the second hour, we'll talk about drugs that are very effective at treating pars intermedia tumors. The downside is that we need a better way to diagnose them based on imaging or with hormone data. The other thing that we used to think, which ended up being quite wrong, is we thought the dog disease and the people disease was similar in that in humans with Cushing's, the vast majority of these tumors are microscopic. They're really small. And so you can't see them often on MRI. You have to do special sampling techniques to put catheters up into the brain and measure gradients to measure ACTH. We thought the same thing was true in the dog, that most of these tumors would be small. And then over the course of the last 10 and 15 years, as we've gone with imaging a lot of these dogs pre-treatment at the time of diagnosis, what we in fact find is that many of these dogs have actually pretty large tumors. We also figured out that you really can't standardize or say that a pituitary tumor of a given size is too big because you're dealing with Great Danes and you're dealing with Pomeranians. Their brain sizes are a little bit different. And so a 1 centimeter tumor in a small dog is much different than a 1 centimeter tumor in a big dog. So what the people in the Netherlands came up with was a scoring system, which is we divide the maximal height of the pituitary by the circumference of the brain at the height of the pituitary, and we get a ratio. And normal dogs have a ratio of less than 0.3. Dogs with macroadenomas have a ratio greater than 0.3. And when we look at all dogs with hyperadrenocorticism, at least the pituitary-dependent form, what we find is that these tumors are in fact quite large. Or what we find is that nothing happens. Does anybody want to guess how big they are? Because there we go. So 2/3 of the dogs have big pituitaries. So when we have a dog who comes into us and they have a pituitary-dependent Cushing's, what I usually tell owners is that there's about a 65% chance your dog has a pituitary that's pretty big. a 33% chance that the pituitary is actually greater than 1 centimeter in height at the time of diagnosis. And the reason that this becomes important is that pituitary tumors, if we just treat the hypercortisolism and we don't treat the mass, then those dogs with big tumors are going to progress to CNS disease, and they're usually going to progress within the next 12 to 18 months. Conversely, at the time of diagnosis, if they have a small tumor, they're going to die of something else. That tumor is not going to interfere with that dog's lifespan because they're crazy slow growing. You can treat that dog for years with medications to control the high cortisols, and it's very unlikely that that tumor will ever progress to cause a symptom in that dog. But it's not uncommon that we'll have dogs presented to us with absolutely no neurologic signs and have really, really big tumors. This is a dog that came in, no neurologic signs. This is his pituitary mass. Dog was clinically normal. So there's not a really good correlation between the size of the tumor and the presence of that dog being messed up neurologically. Now, why is it so common in dogs and not that common in people? We don't really know. What we suspect is that in humans, it's a genetic defect. So people who get pituitary tumors are born with a congenital defect that when they get into their 20s, 30s, and 40s, that tumor starts to grow. And as the tumor starts to grow, it starts to secrete something. So they either show up for signs of Cushing's or signs of acromegaly. This is NBA players, are all acromegalic. They show up with visual field deficits because in people, the pituitary, because of where it sits and how it's encased in bone, the pituitary grows forward. And so the first thing it hits is the optic chiasm. So they usually show up with visual field deficits, one side or the other. Dogs and cats, the sella goes dorsal. So these tumors grow straight up, and they grow straight up into the third ventricle. So there's a lot of space. So we usually don't see any cranial nerve or ocular problems in dogs. When we looked for all of the defects, all the genetic defects that occur in people that have pituitary tumors, and we screen dogs to look for those defects, we don't see it. And so either we haven't found the gene that's messed up, or it's actually not a primary pituitary disorder, and I think that's sort of the leading candidate right now. What we think is that it's rather than being a genetic defect due to a mutation, it's more likely it's a disorder of regulation of the pituitary adrenal axis. So sort of similar to what we were talking about with the horse, we think that what happens in dogs and why it's so common in dogs is that it's really better to look at it as a neurodegenerative disease. It's a disorder not so much of the pituitary as it is of the higher centers in the brain, the hippocampus, that regulates the release of ACTH from the pituitary. And as they lose those neurons as they get older, they'll develop increased urinary cortisol excretion, higher endogenous ACTHs than younger dogs, abnormal suppression on low-dose dexamethasone suppression tests, but they don't have any clinical signs of the disease. So while almost every older dog is biochemically hyperadrenal, only a small subset of those dogs progress to clinical signs that you guys see and that we would see and recognize as Cushing's. So what we think happens is that they develop these areas of hyperplasia, and then some dogs, one of those cells undergoes a clonal expansion, becomes a tumor, and then that dog starts to show all the signs of Cushing's. We've got a lot of evidence that dopamine plays a role in dogs from the use of dopaminergic drugs to treat Cushing's that we'll talk about. Also from some nice studies that were done looking at dopamine concentrations of the brains of older dogs versus Cushingoid dogs versus dogs with adrenal tumors, showing that dopamine levels are actually quite low. The other bit of evidence that we have is if you want to buy, like if you're stuck in an airport one day and you don't know what to do, you should go buy a book called Frozen Addicts. You need to write this down. You're not writing it down. Frozen Addicts. It's written by a guy named Langston. And Dr. Langston was and is a human neurologist working up in the San Francisco Bay Area. And one day in the late 1980s, there was a group of young kids in the San Francisco Bay Area who we will describe as recreational chemists. And what they had done is that they had decided the way to make money was not to get a real job, but was to make stuff in the basement. And what they decided to make was fentanyl, which was actually a fairly good business move on their part, I think. So they started manufacturing fentanyl in their basement, and they had a nice business going. They had some setbacks. They blew up their house one day, and that was an issue. kind of aroused the suspicion of the local authorities, not so much because the house blew up, but because they went to the neighbor 2 days after the house blew up and offered to buy their home for cash. Anyway, they continued to make fentanyl in the basement. One afternoon, it was a Friday afternoon, they made what they thought was fentanyl, and they sold it to 6 people who were between the ages of 18 and 25. And those 6 people went home throughout the San Francisco Bay Area and injected themselves with what they thought was fentanyl. And the problem was, within 30 minutes, all 6 of them lost the ability to talk. Within about another hour, they were unable to use their arms. Another half hour, they couldn't use their legs. They were completely frozen. And they ended up going into 3 different ERs in the San Francisco Bay Area, one of which Langston was working at. And they called Langston in to look at these 2 kids, because everyone's sitting around going, what in the hell's wrong with them? And he goes, I know what's wrong with them. This is end-stage Parkinson's. This is full-blown Parkinson's at its grandest scale. And, of course, he came into that diagnosis because that's what he studied. He was a Parkinson's researcher. And he was very bummed out because Parkinson's does not occur in any other species but humans, and we're very bad experimental animals. So he went back and said, this is all very weird, figured out that these 2 kids in his hospital were intravenous drug users, found out from the relatives where they had been earlier that day, contacted the authorities. They went to the house where they made the stuff and found out that afternoon they didn't make fentanyl. They had made something called MPTP. And MPTP is very closely related to fentanyl, but when you inject MPTP, it's a very potent dopaminergic neurotoxin. So these kids had basically killed every dopaminergic neuron in their brain. So Langston, not happy about that circumstance, but thrilled about this stuff, injected it into mice and they became Parkinsonian, injected it into rats and they became Parkinsonian, injected it into monkeys, they became Parkinsonian. And then I met him because I was at Stanford at the time, and I said, hey, did you by any chance inject this into dogs? And he goes, yeah, we did, and nothing happened. They didn't develop any signs of Parkinson's disease, but they all, he had lots of blood samples on them. And what we found is that all of the dogs all developed biochemical signs of hyperadrenocorticism. And so it lended some evidence that the role of dopamine is probably important in the dog, but dopamine doesn't seem to be very important in motor movement in the dog. It's a great book because when you read the book, you find out all the intrigue of NIH and people arguing over who discovered MPTP. It is a mess. None of those 6 people did well. I will have to tell you that. Don't take illicit drugs. Number 1, and if you're going to, get it from somebody you trust. Now, the classic signs of Cushing's are all related to the stuff that you see every day. So high levels of cortisol interfere with antidiuretic hormone, both at the pituitary and at the kidney. So severe PUPD, probably the most common reason why the dog presents. They're polyphagic from the catabolic effects of the glucocorticoids. They get nice abdominal distension, hepatomegaly from the catabolic effects, again, of steroids, and the glycogen deposition in the livers. You probably had owners who complain about dogs panting a lot who have Cushing's, or dogs on high doses of pred who pant. We used to think that was a lung problem, that there was something going on in the lung. And there was actually a paper that came out and showed that dogs with Cushing's had increased airway mineralization versus dogs that didn't have Cushing's. But it ends up that if you just look at old dogs, there's no difference between old dogs and Cushingoid dogs. Airway mineralization is just an aging process. The reason that they pant is the same reason that about 20% of Cushingoid people hyperventilate, is that it has an effect on the brainstem and is telling them to hyperventilate. So it's a CNS effect. When you're for Cushing's, if you're still having panting and you're undergoing medical treatment, probably your 24-hour cortisols are still high. It should resolve. Yeah, it should definitely go away. You've seen the dogs with they're obese, and people develop what's called central obesity. So they have peripheral muscle wasting, but big abdominal fat pad accumulation, same things in dogs. They don't necessarily have to be gaining tremendous amounts of weight, but what they're doing is redistributing their weight. They become very lethargic from the catabolic effects and the muscle weakness, exercise intolerance. If they're intact, male or female, they'll either go into anestrus or they'll develop testicular atrophy. That's because all the glucocorticoids that's floating around go up to the pituitary and suppress the release of FSH and LH. Nobody really cares that much about this in dogs because, they're 14 years old. They shouldn't be having sex anyway. So it's usually not a chief complaint. Derm signs, crazy common. A lot of dogs have adrenal function tests done as a result of some suspicion that Cushing's might be present. The bilaterally symmetrical endocrine alopecia, characteristic of all endocrine disease, very common in Cushingoid dogs. We used to stay awake late at night and wondering why dogs with Cushing's had hair on their head and hair on their feet, but hair nowhere else. I thought that was very troubling. And then the people at Utrecht, again, did a study looking at the distribution of steroid hormone receptors in the skin and found that the distribution of the steroid hormone receptors mirrors the alopecia. And I thought, well, that's phenomenal, but why do they have steroid hormone receptors in their skin? So now I can't sleep because of that. It's not fair. This is calcinosis cutis, virtually pathognomonic of too much steroid, whether it's endogenous or exogenous. So it's these raised, erythematous, intensely pruritic plaques. The thing with these lesions is if they don't get recognized as calcinosis cutis, a lot of dogs get placed on glucocorticoids to treat the pruritus. It's really good for that. It'll stop the pruritus, but the problem is the calcinosis cutis progresses. And dogs with calcinosis cutis, it's tough. It takes a lot longer to get their Cushing's under control, to get the skin lesions under control. Behavioral symptoms, again, in people, this is the most common reason why people get diagnosed with Cushing. So a nice study recently came out showing that over 90% of people diagnosed with Cushing's are diagnosed by their psychiatrist first. So they're presenting for behavior change, not because they're PUPD, panting, wetting the bed. They're not doing any of that stuff. They're just wacko. And the psychiatrist he orders a urinary salivary cortisol, and it's high, and then they send them to the endocrinologist. Sleep-wake cycle disturbances in dogs are pretty common as well. So these are owners who will complain that the dog is up at night, aimlessly wandering around the house, and then sleeps quite soundly throughout the day. Same thing in people. And all of those things should reverse with treatment. So when we talk about trying to diagnose Cushing's, I guess I should say, working for the Evil Empire, we're Antec. How many people use Antec for endocrine tests? How many people use IDEX? How many people use somebody else? Okay, so as we talk about these tests that we're going to talk about, and you look at the numbers, these are going to be Antec normals. When you look at percentages in these numbers, the percentages are virtually going to be the same between all the labs. I think most of us agree on diagnostic criteria. It's just that the absolute numbers are probably going to change a little bit. So the first thing that you're going to do as you're working up a dog for Cushing's is you want to make sure that there's nothing else wrong with the dog. And the reason is twofold. One is that they're older dogs, so there's a good chance that something else is wrong with the dog, that he may have Cushing's plus something else. And that's going to be important to know because we're going to want to address whatever that other thing is. And whatever those other diseases are may affect what we're going to do in terms of either diagnostic tests or treatment options, how we're going to treat that dog medically. So the first thing that you want to do is you want to do a complete database on these dogs. So certainly we're going to do a CBC and a chem and a UA. You're going to want to culture their urine because there are two papers, one from Virginia, one from Texas A&M, showing that dogs with hyperadrenocorticism, about 30% of them have UTIs, even though they're not symptomatic for the UTI. And even if when you do a urinalysis, you don't see pyuria and bacteriuria. And the reason you're not going to see pyuria and bacteriuria in a lot of these patients is because, one, their urine's dilute, so you're not going to see anything. And the other is that Cushing's an immunosuppressive disease. So it suppresses the pyogenic response to the infection. So you probably should just go ahead and routinely culture their urine. Same thing with diabetic dogs and cats. Same issue. It's an immunosuppressive disorder. You will certainly want to do other tests, imaging tests, radiographs, ultrasounds, etc., depending on what you found on your physical, depending on what else comes back on the lab work. We'll talk about the role of imaging like CT and ultrasound and MRI to differentiate pituitary from adrenal-dependent disease. But at this point, we're still in the process. What we're talking about here is, do you want to take radiographs because you found something else wrong? When we go to actually make a diagnosis of hyperadrenocorticism, we really have three screening tests that we can use to make a diagnosis. One is we can do an ACTH stimulation test. The other is we can do a low-dose DEX suppression test. And lastly, we can do a urine cortisol to creatinine ratio. So let's say that for the purposes of discussion, that you guys, when you go back to work, you're presented with a dog that looks like a classically Cushingoid dog. How many of you would start with a stim test? How many would start with the low-dose DEX? How many would start with the urine cortisol to creatinine ratio? Okay, fascinating. Okay, so first of all, congratulations to you, because most people don't raise their hands, and this is where I have to chastise people and say this is what's wrong with our country, that people don't vote. But apparently we're in a voting block here, so that's excellent. The second thing is, why basically does no one agree? Why do we get 3 different answers? Why doesn't everybody say, oh yeah, we use this test?
They all have their advantages and drawbacks.
Yeah, they all suck. I mean, so the bottom line is, we have people call the lab every single day and they say, look, I don't want to listen to Bruette talk. I don't want to read anything. I want to test the dog for Cushing's. Which frickin' test should I use? And I say, yeah, they're all equally bad. They're all look at 3 different things. So an ACTH stim test is asking the question, does this dog have adrenal hyperplasia? Does he have a sub-maximal response to an injection, an exogenous injection of ACTH? The low-dose DEX suppression test is asking the question, is there normal feedback between the adrenal and the pituitary? And that's really the hallmark of Cushing's, is the loss of the negative feedback. And then the third test, the UCCR, is really asking the question, in a 12-hour or 24-hour period, is that dog secreting more cortisol than a normal dog? And there's been a gazillion papers written on which of these tests are better than the other. And there's been some papers written on what are called discordant test results, which means, let's say you have a dog who tests positive on one but negative on another. Well, that's not discordant, that's just life. Life is not fair. And so what happens is that if you do an ACTH stim test on that floridly Cushinoid-looking dog, what are you going to recommend to the owner? He still has all the same symptoms that you were evaluating him for at the stim test. That comes back and says everything's fine. What do you tell the owner at that point? Do another test. Pick another test that looks at a different part of the pituitary adrenal axis. So if they have a normal stim, do a low dose. If the low dose comes back normal and you think, I think that dog has Cushing's, then you're going to stim him. And then when both of those come back normal and the owner's getting really agitated, then we're going to talk about weird stuff that they can look for, like sex steroid overproduction or these food-induced Cushing's things. But you don't want to stop the workup just because one of the tests comes back normal. So let's talk a little bit about each of the tests separately to talk about, like what you mentioned, some of these tests are good and some of them are not so good. The reason a lot of you, probably the majority of you, I think, raised your hand to the low-dose DEX, one of the reasons why you probably like the low-dose DEX is because if you look at separating Cushinoid dogs from normal dogs, it gives you the right answer 90% of the time. So that's pretty good. But what it also immediately tells us is that 10% of Cushinoid dogs have a normal low-dose DEX. Well, how can that be? The dog's hypersecreting cortisol. He's got a pituitary tumor or an adrenal tumor. How is it that he still has a normal low-dose DEX? Well, probably what's happening in those dogs is that they're early in the disease state. They're early in the disease. So while they've lost feedback under normal mechanisms, they still respond when you give that dog an IV injection of dexamethasone. Okay? So again, if your low-dose DEX is normal, either he truly doesn't have Cushing's, or he's 10% of dogs with Cushing's that have a normal low-dose DEX, in which case you're going to call the owner and say, we should probably stim your dog. Bring the dog back in. Some people don't like the low-dose DEX, especially owners, because it takes 8 hours. And there are people on the planet, these pet owners, who think that their dog will explode in the 8 hours that it's in your clinic. It cannot touch the ground. It can't be away from the owner. They don't want to deal with that. So that's a bad thing. But the good thing about the low-dose DEX is that it takes 8 hours. And we can use that information that we get during that 8-hour time period not only to say yes or no to hyperadrenocorticism, but to try and diagnose pituitary-dependent hyperadrenocorticism, which means if that works out, there's only one test and 1 day that have to be done to diagnose and distinguish between the two diseases. So that's probably the biggest reason why we like the low-dose DEX, is because it offers that advantage. Another thing to remember about the low-dose DEX is that if you're the second or third vet to see the dog and the owner has no idea what medications the dog is on, comes in a little envelope, give one twice a day, or they're putting stuff in the ear or the eye of a dog that weighs less than 15 pounds, then we have to worry that it's iatrogenic Cushing's. And if we're worried about exogenous steroids causing the clinical signs, the only test we have to diagnose iatrogenic Cushing's is a stim. A low-dose dex isn't going to work because basically a dog who's receiving exogenous steroids is undergoing a daily low-dose dex. He's already going to be low. So we need to stim that dog to show that his adrenals have atrophied. Now, how many people, again, use Antec? Okay. And again, IDEX does the same thing. I'm a little bit more familiar with the Antec form since I work for them. But when you do a low-dose dex suppression test, you get back this beautifully written thing, right? That says, it's like this long. It says if X is Y, then B is D, then go to here, and you get 50 different things, right? First of all, when you read that, you read it and you go, this is true prose. I've never read anything so beautiful in my entire life. The word pattern flows, right? Right? Yeah, I know, because I wrote that, so that's really good. The problem is that I know that you don't read it, because nobody reads it, because they call the 1-800 line and they say, I don't understand the low-dose dex, and you go, what the hell's not to understand? It's the numbers, there's a chart, call me back. So what we're going to do is I'm going to show you how to interpret the low-dose dex and not call and not have to read the form. It's a win-win for everybody. So the first thing you want to do, and this applies to IDEX as well, when you get 3 cortisols back on the low-dose dex, go to the 8-hour cortisol. If the 8-hour cortisol is high, above whatever the cutoff is, that dog has hyperadrenocorticism. Okay? If the 8-hour cortisol is suppressed, if it's low, if it's below whatever number the lab is giving you, what does that tell you about that dog? So you get back a normal low-dose dex, 8-hour cortisol suppressed. 2 possibilities. He's a normal dog, he doesn't have the disease, or he's 10% of dogs running around with Cushing's that's suppressed on the low-dose dex. So let's say your 8-hour cortisol is high. Now you care about the other cortisols. And now you ask the question, at any time point during that 8-hour test, do I see at least one cortisol that's 50% lower than the others? And if the answer to that is yes, it has to be pituitary. It will not be adrenal. If at any time point during that 8-hour test, if you have at least one cortisol that's 50% lower than the other cortisols, it has to be PDH. Okay? Adrenal tumor dogs will never suppress to that degree on a dex suppression test. All right? So does that make sense? 8 hours high, 50% suppression. Okay? Agreed? Simple? Because here's what's going to happen. I'm going to show you 4 examples and you're going to muck it all up. I'm just guessing. You maybe not, maybe not. So this is going to be the same. All 4 slides are going to look the same. You're going to have microgram per deciliter cortisol values on the vertical axis. We're going to have our 0, 4, and 8-hour samples on the horizontal axis. We're going to call this Dave's lab to take Antec and IDEX out of the equation. Plus, I'll be starting that lab here shortly. For our lab, we're going to say the 8-hour cortisol should be less than 2. Okay, 8-hour cortisol should be less than 2. So your first patient has a resting cortisol of 10, a 4-hour cortisol of 10, and an 8-hour cortisol of 10. Normal 8-hour cortisol is less than 2. How many people vote this dog has hyperadrenocorticism? How many people say he does not have hyperadrenocorticism? How many people are very confused? It's very sad. Also, a big chunk of you didn't vote. See, again, and this is the issue that we're going to have. So unless you're suffering from some paralytic disorder that allows you not to be able to raise your arm up in the air, then we have a problem. Okay, so by definition, 8-hour cortisol should be less than 2. His cortisol is 10. 10 is greater than 2. We can agree with this. By definition, he's hyperadrenal. Okay, now we care. So we go back and we look at the other cortisols. At any time point, do you see any cortisol 50% lower than the other cortisols? Dear God, say no. Right? It's flat. 10, 10, 10. Okay, here we go. Time to vote. How many people vote this dog has pituitary-dependent disease? Raise your hands high. This is what it'll look like. Okay? How many people vote it has adrenal-dependent disease? Raise your hands really high, because that's the most number one screw-up on the low-dose dex. So sad. Okay, so here's the deal. Let's go back and talk about adrenal tumors first of all. Let's say that you have a dog with a right-sided adrenal mass secreting cortisol. That thing's pumping out tons of cortisol. Your pituitary gland is normal. High levels of cortisol go up to the brain, shut off ACTH, contralateral adrenal gland atrophies. Okay? That's what's happening with your basic adrenal-dependent dog. When you do a DEX suppression test on a dog, you're not testing his adrenal function. You're testing his pituitary function. Okay? So if you have a dog with an adrenal tumor and he's secreting massive amounts of cortisol and his pituitary is normal, what will his ACTH level be? It would be crazy low. Okay? His pituitary is normal. He sees too much cortisol, shuts off ACTH. His endogenous ACTH is low. You give him dexamethasone, you can't make it go lower. So an adrenal tumor dog is going to secrete cortisol at whatever rate it's going to secrete cortisol. So you are partially correct. This is totally consistent with an adrenal-dependent dog. Bad news is that 25 to 30% of dogs with pituitary-dependent Cushing's have a pars intermedia tumor. They never see the dexamethasone. There's no blood supply connecting it. So that pituitary tumor is secreting ACTH at whatever rate it's going to secrete ACTH. Never sees the dexamethasone, so cortisol levels aren't going to suppress. So failure to suppress on the low-dose dex doesn't give you any information about origin. Is it pituitary or adrenal? The only thing we can say about this particular dog is that, yeah, he's clearly hyperadrenal, but now we have to do something else. And we'll talk about those differentiating tests in a minute. Here's a second dog. Resting cortisol of 10, 4-hour cortisol of 6, 8-hour cortisol of 4. Normal 8-hour cortisol should be less than 2. How many vote he's hyperadrenal? Yes, everybody, thank goodness. Do you see at least 50% suppression at any time point during the 8-hour? Yeah. Okay, good. So 4 is less than 50% of 10. This has to be pituitary. It cannot be adrenal. Now, why do I tell you it can't be adrenal? Because we've got gazillions of papers and patients showing us that an adrenal tumor dog over an 8-hour period never has that big of a fluctuation in cortisol levels. Okay, you're never going to see 50%. So when you get that result back from the lab, you can go to an owner and say, yes, your dog has Cushing's. Yes, it's pituitary. Now we can talk about how we're going to treat that. He doesn't need any other endocrine tests. Okay, now you can just talk about treatment. This is the most common thing we see in the lab. So this is called the V pattern. So you have a resting cortisol of 10, a 4-hour cortisol of 4, 4-hour cortisol of 4, 8-hour cortisol back at 10. 10's higher than 2. He's hyperadrenal. Do you see 50% suppression at any time point? Yeah. How many people vote it's pituitary? How many people vote it's adrenal? How many people say, I want to go home? We're going to the baseball game. Okay, so why is it that this one's different than the previous one, that people aren't all raising their hands and saying it has to be pituitary? What bothers you about this? Something's bothering you. Tell me. I care. What you're probably bothered about and why people call us is they say, well, yeah, it went down 50%, but it went back up. Why did it go back up? Really good question. So a couple of years ago, Deb Greco did a really nice study in dogs with Cushing's and demonstrated that when you're Cushingoid and you're swimming around in a sea of cortisol, your liver is crazy metabolizing cortisol. Metabolizes cortisol at a much higher rate than a normal dog. Well, surprisingly enough, she found out that they really degrade dexamethasone much faster than a normal dog. So if we give a normal, healthy, non-Cushingoid dog 0.01 mg per kg of dexamethasone IV, how long do you think his cortisols stay low? How many hours after dex?
8.
Well, at least 8. The reason that we actually do 8 is because that's when veterinary hospitals are open. It has very little to do with physiology. It's actually 24. So dogs are exquisitely sensitive to low doses of dexamethasone. So their cortisols will stay suppressed for about 20 to 24 hours. However, what happens in the vast majority of Cushingoid dogs, especially when they've had Cushing's for a while, is that what happened here is that you gave him dex, you suppressed ACTH, so his cortisol levels started to come down. He clears the dexamethasone, his ACTH levels go back up, his adrenal starts producing cortisol again. So back up at 10 hours, he's back to where he was. He's back at baseline. But he had 50% suppression at least one time point. It still has to be pituitary. Doesn't matter when it occurs. during the time course of the low-dose dex. And for those of you who are my age, you may remember that we used to do this every 2 hours. We used to do a pre 2, 4, 6, and 8, and we stopped doing all of those samples because we realized the diagnostic value lied in the 4 hour. That you could get the same material, the same information, taking 3 samples as you could taking 5 samples from the dog. So again, this is another dog. You go to the owner and say, yes, it's Cushing's, yes, it's pituitary, and then you talk about options. This is the last one. We'll make the pain stop. Normal dog, or I shouldn't say that. Oh, crap. Starts at 10. 4 hours is at 6. 8 hours is less than 2. Normal suppression is less than 2. How many people voted to normal dog? See, I screwed you up because it's not a normal dog. 10% chance it has Cushing's, right? 10% chance. So what this test tells you is if that dog looks Cushingoid, then I got to go do something else. And at that point, you're probably going to do an ACTH stim test. Now, for those of you who like the stim test, you probably liked it because it's fast. You know, depending on what we're using to stim them with, it's a 1 or 2 hour test. If you look at the diagnostic accuracy of the test, remember with low-dose dex, we said 90%. So 90% able to differentiate normal versus Cushing's. ACTH stim test, we're looking at 80 to 85%. So not as accurate as the low-dose dex. Means 15 to 20% of dogs with Cushing's have a normal stim. Well, how can they have a normal stim? They probably have a normal stim because they don't yet have adrenal hyperplasia. And my guess would be if you ultrasounded that dog, what you would find is pretty normal looking adrenal glands. And as we'll talk about in a minute, imaging, whenever we have imaging data that doesn't correlate to endocrine data, we always go with endocrine data. So these are dogs that probably if his stim test is normal, he either doesn't have Cushing's or, again, he's early in the disease process and he hasn't developed big adrenal glands yet. Like we said earlier, this is the test that you want to do if you think it's iatrogenic. And if it's an iatrogenically Cushingoid dog and you stim it, what will the pre- and post-cortisols look like when they come back from the lab? A deafening silence. Not good. Let's start again. What are they going to look like? Are they going to be high or low? They're going to be low, right? So you've been giving him steroids, suppressed his pituitary, ACTH drops, bilateral adrenal atrophy. You give him a single dose of ACTH, nothing happens because he doesn't have any adrenal glands. Okay? So you're going to get back a pre and a post cortisol, they're going to be low. He's going to look Addisonian. So when you have a dog that looks Cushingoid and a low stim, you got to go back to the owner and say, okay, something's wrong here. And we got to find out, is he getting anything topical in his ears, in his eyes, in his anal sac, whatever, eye of newt, something's going on there because he's under the influence of steroid. Now, how many people use Cortisol for the stim? How many people use compounded preparation? Okay, good. The really nice paper that came out looking at Cortisol versus 5 different compounded ACTH preparations. And so what they did is they got 5 different compounding pharmacies to send them vials of ACTH, 40 units per mil. Did ACTH stim tests and compared those to a Cortisol stim test in normal dogs. And what they found was that there was no difference in the numbers. There was no difference in the post-ACTH cortisol response, whether you used compounded or whether you used Cortisol. However, the problem came was that when they took those 5 vials that were supposed to be 40 international units per mil, and they sent it to a reference lab and said how much ACTH is actually in here, it varied from 0 to 1,000. That's a problem. And so what that tells us, first of all, is that dogs don't need a lot of ACTH to stimulate their adrenals. So even the doses that we're using now may be higher than what we need to use. And it looks like it probably would not affect your ability to diagnose Cushing's, but the reason I'm not a big fan of compounded ACTH is in monitoring patients on treatment. Because if you have a dog who's on long-term treatment with trilostane or Lysodren, and you're stimming them all the time, and you're getting weird numbers, the weird number may be not from the drug and what you're doing. The weird number could be the amount of ACTH that you're giving the dog. So what we try and do is encourage people to use Cortisol, use the low dose, the 5 microgram per kilogram dose, give it IV or IM, doesn't matter how. If you're not going to use a whole vial of Cortisol in 30 days, draw it into a plastic syringe and freeze it. And it's good frozen for a year. once you thaw it, you can't refreeze it, but it's good frozen for 1 year. So you should be able to get lots of stim tests out of that 1 vial of Cortisol. Now, urine-based testing has advantages and disadvantages. The advantages are it's insanely sensitive. By definition, it's virtually impossible to have a dog with Cushing's who's not secreting more cortisol than a normal dog. The only time that's going to happen are that small population of dogs with atypical Cushing's that's secreting a sex steroid, which won't cross-react in the urine, or a dog with meal-induced Cushing's who hasn't eaten in 12 hours. Otherwise, they should be high. The problem with the test is it's very low specificity, meaning that lots of things make urine cortisol go high. So the way the test was originally developed was that the owners were obtaining the first morning voided urine sample from their dog at home, and they collected urine 3 mornings in a row, and they mixed the urine together, and they brought that urine sample to the vet, and the vet submitted that to the lab. And if you do that, it's very accurate. Okay, you get very, very few false positives. What we tend to see what happens, though, is that the dog wakes up in the morning, he goes outside and he urinates, he comes in, he gets in the car, he goes to the vet, he goes into the exam room, he goes into the treatment room, he gets rolled on his back, somebody rams a large gauge needle into his ventral abdomen, and you get a urine cortisol to creatinine ratio that's shockingly elevated. Well, that's just the dog. So urine-based testing ideally should be done in the home environment, preferably multiple mornings pooled together, and then it can be good. But otherwise, you can kind of use it to rule stuff out, but we don't usually use it to rule stuff in. Like, I'm not going to make a diagnosis of Cushing's based solely on a urine-based test. We're going to do either a stim or a low-dose dex to confirm it. Now, let's talk a little bit about distinguishing between them. So let's say you did a stim test on the dog and it came back high, or you did a low-dose dex and you didn't suppress at 8 hours, but you did see 50% suppression at some point during the test. So now you don't know what he has. One of the things that commonly happens at this point is the owner goes, yeah, time out. I don't have any more money. I don't want to spend any more money on diagnostic tests. Can't we just treat my dog? You've told me my dog has Cushing's. I'm not going to do an adrenalectomy. I'm not going to do pituitary radiation or surgery, so let's just treat my dog. It's a very good question. To which what I usually tell owners is that I understand that, but there's probably at least 2 reasons why you might want to know whether it's pituitary or adrenal, and I might want to know, even if we're going to treat the dog exactly the same way. For instance, the dog's going to go on trilostane or Lysidren. So what might be 2 reasons why a pet owner may want to know what form of disease their dog has? Prognosis, okay? Let's talk about prognosis. And I'm going to tell you this because you're probably going to support me in this. I'm co-author of a bill going through the California legislature right now, SB 1394. SB 1394 states the following. If you're a pet owner in the state of California, you will be microchipped. However, the microchip does not contain any information related to medical crap. What it contains is a little RF receiver that when a pet owner approaches a computer hooked up to the internet, it turns it off. Because the owner is going to know the answer to the questions that I'm asking you right now because you've told them their dog has Cushing's. The night before, they have spent a solid 10 minutes researching Cushing's. They're going to come in and tell you, I read up on this. I know what's going on. And the first thing they're going to say is, and I love these people now. I used to hate them, but now I just love them. I just sit down and go, okay, that's fascinating. Let's hear about it. Did you go to Uncle Billy Bob's Cushingoid website? I mean, where exactly are we getting your information? What is the prognosis for a dog with pituitary-dependent Cushing's? They're going to know the answer to this. How long does the average dog live with PDH that undergoes treatment? 26 months. That's the number that they're fixated with because that's the number that pops up on the internet. The number is completely accurate. It was taken from a study of 200 dogs treated with OPDDD, followed them until they croaked. Average life expectancy is 26 months. Now, here's the problem. Very few of them go to actually get the paper and actually read the paper because what they would discover is the average age at diagnosis was 14 and a half years. Now, here's a shocker for most pet owners. 50% of 17-year-old dogs are dead. So there's a pretty good chance that your 17-year-old dog will be dead when it's 17. Probably not going to die from Cushing's, however. is probably going to die from some other 17-year-old dog disease. And as an internist, I've always viewed my job as I have one job, and that's to keep the dog or the cat alive long enough to get cancer, and then I give it to the oncologist, and I say, well done me. I've kept this thing going, and something else is going to claim it. So yes, 26 months. But the thing they have to understand is that doesn't apply to their 9-year-old Bichon that you're diagnosing with Cushing's. Otherwise, they go home and they start counting the clock. My dog's going to die in 26 months. Now, my dog's going to die in 25 months. When I was a resident, I saw a Doberman with DCM. Bad deal. And I was a super smart resident at Davis, and I was on cardiology. I saw this Doberman with DCM. We did an M-mode DCM. The week before, this paper came out on survival of Dobermans with DCM. I read that, 24 days. Walked into the exam room. Your dog's going to die in 24 days. The lady fainted. On day 25, she called me. He's still alive. On day 41, she called me. He goes, he died. So I don't give people that kind of information anymore. It's just not helpful. So the average prognosis for pituitary dependent is 26 months. Now, an owner who's really evil will say, how long is he going to live if I don't treat him? What's the survival of an untreated Cushingoid dog? It depends. You're not going to find that information on the internet because there is no such paper. No one has ever followed 100 dogs to death that were non-treated. And you all have clients who are insane. These are people who will deal with bald, calcinosis cutis, peeing in the house, crazy pancreatitis, throwing emboli, non-ambulatory, and you say, how's the dog? And they say, he's doing great. Eats well, everything's fine. And then you have people, and the dog pees in the house twice, and they're dead. That's it. They're going to be euthanized. So there is no good data, and that's what I tell people. We treat the symptoms. We're here to treat the symptoms of the disease. If your dog has bad symptoms, I can improve the symptoms. If your dog has no symptoms, we don't treat Cushing. You know, if we're diagnosing it strictly because somebody found a high alk phos and a big liver, and they wanted to know what that was about, and we diagnose Cushing's, I tell people, well, look, there's no reason to treat because we have no evidence that treating now prolongs survival or improves your dog's quality of life. Okay, so we don't treat. What about adrenal tumor dogs? How long do they live? The first question. What percentage of dogs with adrenal-dependent Cushing's have a carcinoma, malignant? 50. 50-50. Adrenal-dependent Cushingoid dogs with adrenal carcinoma, that's bad mojo. Okay, that's a very short survival time. 3 to 6 months. Not good. Dogs with an adrenal adenoma causing Cushing's disease, they can live a long time. Okay, if the tumor doesn't invade into the cava, it's not going to metastasize because it's benign. It could invade into something. Could rupture if it gets really big. But those dogs can live for a long time. It's harder to treat them. It takes more monitoring, higher doses Lysodren, higher doses of triostane, but it's a manageable thing if they don't want to do an adrenalectomy. So if we're thinking where the dog may have an adrenal tumor and they're worried about, how long is their dog going to live, or they're worried about a pituitary tumor and how long is their dog going to live, then we talk to them about, okay, you can do these 3 screening tests. And the 3 tests that we have is that we can either do another suppression. Now, though, we're going to give them 10 times the dose we did in the low dose. We're going to measure ACTH from their pituitary, or we're going to do some kind of imaging study, whether we're going to image their abdomen with CT or ultrasound, or we're going to do something to image their pituitary. So what we'll do is we'll go ahead and I have to stop. We'll take a break. I think you have a 30-minute break. Is that what happens on the thing? And then we'll come back in 30 minutes. We'll finish talking about distinguishing, and then we'll talk about treatment options. And I'll be here if you have any questions while you're taking your break.